Hi everyone, welcome to researchmd.com. Today our topic is about dizziness. How to evaluate somebody, a patient came with a dizziness. Let's look at that, okay? Again, my name is Pramil Cheriyath. I work as a program director, internal medicine residency program and transitional residency program. I also work as a director of research and I'm an assistant professor of medicine at Hackensack School of Medicine. So let's jump into dizziness, okay? Now, what is dizziness? When you talk about dizziness, they always say difficult is the word. The dizziness equals difficult. Why is that? Everybody have problem, like, how to evaluate dizziness. What does the patient, what do they mean when they say dizziness, okay? Several terms kind of use it. So mainly we can say to describe maybe altered sense of balance, play, such as lightheadedness, feeling faint, weak, or unsteady. And dizziness that create a false sense or like your surrounding or spinning, and then you have to think about like it's called a vertigo. Okay, so let's look at the next one. General approach to dizziness. A complaint of dizziness is very non-specific. Remember, dizziness equal to difficult. So dizziness is a broad term. I mean, disorders like vertigo, presyncope, syncope, disequilibrium, okay? So it's very, very important. You have to take a detailed history of the physical examination when the patient come in with the complaining of dizziness. Most of your diagnosis 95% of your diagnosis come from a history taking. Always ask open-ended questions and evaluate for any positional changes, orthostatic BP changes, and gait, and also looking at nystagmus also is very important. So you can come with a good hypothesis, okay? Now, common cause of dizziness. A number of conditions cause dizziness, right? Vertigo, it could be like peripheral vertigo or central vertigo, okay? And then you can have inner ear disorders or most frequent cause of dizziness. Now, if you look at the peripheral vertigo, we made this nice table. We're going to look at the difference between benign positional vertigo. We're going to look at the Meniere's disease. We're going to look at the labyrinthitis. And we're also going to look at vestibular neuritis. There's four things you need to differentiate. Now, when you look at the first one, let's look at the duration of the vertigo symptoms. In benign positional vertigo, it's usually seconds, and the patient feels better after that. In the Meniere's disease, hours to day, and when you talk about labyrinthitis, day to weeks, and vestibular neuritis could be day to weeks. Now, let's look at the characteristic of the vertigo. In benign positional vertigo, it's like paroxysmal. That's why it's called BPPV, benign paroxysmal positional vertigo. Meniere's disease, like again, episodic. Labyrinthitis is continuous, and the vestibular neuritis is also continuous, okay? Postural, benign positional is postural, and Meniere's disease is not postural, and labyrinthitis not postural, and vestibular neuritis is also not positional. Hearing loss is another one. You have to know the differentiate, okay? In benign positional vertigo, you will not have any hearing loss. But at the same time, when the patient comes with the Meniere's disease, there's going to be hearing loss. Labyrinthitis, there's going to be hearing loss. And vestibular neuritis, there won't be any hearing loss at all. And URI association in the benign positional is no, Meniere's disease no, and labyrinthitis, yes, you're going to have like, upper respiratory infection kind of related symptoms, and vestibular neuritis also, you can have those symptoms. Now, let's start with the BPPV or benign paroxysmal positional vertigo. What are the usual? Let's look at some of the complaints where the patient usually present with, okay? When I woke up, the room was spinning and it comes and goes, okay? Paroxysmal. When I turned my head to the right or left, everything was spinning. Relation to the head, remember that. When I bent over, the room was spinning. Anytime you say like somebody said, room was spinning, and I had the symptoms before, it kind of comes paroxysmal, okay? Now, if you look at a little bit of epidemiology, there was a German national telephone health interview survey done in 2003. We're just looking at some of the evidence. Lifetime prevalence is like 2.4%, and in the females is almost double, like 3.2%. 1 year prevalence is 1.6%. 1 year incidence is 0.6%. Median duration of an episode 2 weeks. Need for medical consultation. 86 of the affected participants have like some medical consultation. Effective treatment receive around 8% of the affected participants. No, let's look at the pathophysiology in the benign proximal positional vertigo. It's attributed to the calcium carbonate and the protein crystals called otoconia debris settling within the semicircular canal. We got this nice picture, and after being dislodged from the utricle. Okay, so you got calcium carbonate and the protein crystals, the otoconia debris settling within the semicircular canal after being dislodged from the utricle. When the otoconia are in motion, the patient experiences conflicting signals from two labyrinths, resulting in brief but there's an intense period of vertigo. Okay. Now, clinical symptoms, again, German National Health Survey, 85% when turning over in bed. Remember that. Okay, 74% when lying down, 58% when rising up from a supine position, and 55% bending forward, 41% when reclining the head relation. Most of them, 85%, when they're turning over in bed, they were having symptoms. Next one, we're going to look at the Meniere's disease. What are the patients complain they usually present with? They're going to say, I have many episodes of dizziness with the nausea and it prolonged for hours and every time. I feel a lot of pressure in my ear. I feel ringing, tinnitus, right? Ringing sound in my ear each episode. There's no effect on my head movement, on my dizziness, okay? So let's look at some of the epidemiology, overall clinical practice research data, link some information. Overall incidence is 100,000 per people is 13.1. Incidence rate male 9.5. Again, female to male ratio, look at it, females have higher. Average age 55.8. And remember, the incidence increased with age, okay? Mean BMI was 26.6. Pathophysiology is still not very clear, but there is like inability of the ear to regulate the endolymph. It increases the endolymph within the inner ear, causing endolymphatic eye drops. And it can hypothesize that isolated symptoms like fluctuating hearing, episodic vertigo are related to this eye drops restricted to certain portion of the labyrinth. Okay. Now, clinical symptoms, you have the triad: unilateral sensorineural hearing loss, vertigo and tinnitus, ear fullness on the affected side, decreased hearing. Remember, in this decreased hearing and reduced vestibular sensitivity is noted of the affected ear, generally increased with the disease progression, no association with the head movement, while BPPV has relationship in the head movement. Okay. Now let's look at another labyrinthitis and the vestibular neuritis together. What does the patient usually complain of? The room just started spinning and it does not stop. Remember the stop, it's kind of continuous, okay? I'm having a constant dizziness and nausea for 2 days. Again, longer duration. I'm having some hearing loss in my right ear, along with the ringing sound. It started 3 days ago. I also had like viral infection a week ago. We talk about the upper respiratory infection, in the beautiful slide we had before. Remember that. Pathophysiology, the mainly is thought to be a result of there is inflammation of the 8th cranial nerve, the dysfunction of the superior division of the vestibular nerve. Okay, it can also complication of stroke that is involving the artery close to the inner ear. Other causes like herpes simplex, Epstein-Barr, rubella influenza, CMV virus could also be thought of the cause. Clinical symptoms, you got sudden onset of vertigo, it lasts more than 24 hours, longer duration. Always remember that. It's usually restricted to single continuous episode of vertigo. Unilateral sensorineural hearing loss is present in labyrinthitis. So this is another thing we have to remember. Unilateral sensorineural hearing loss is present in labyrinthitis, but it's absent in the vestibular neuritis. Always a very good point to remember, okay? It's associated with the nausea, vomiting, postural inability, associated with history of upper respiratory infection. Again, intensity of vertigo is not in association with the head movement. Remember that. All the symptoms kind of help you differentiate. Now, the next most important thing is, anytime somebody with the vertigo, dizziness kind of symptoms, look at the nystagmus. What is nystagmus? It's an involuntary rhythmic oscillation of the eye. Vertigo and dizziness or loss of balance are almost always present when nystagmus is related to the problem. As the canalith move, their ability to drag the endolymph behind them and stimulate the hair cells to the cupula, causing vertigo and the nystagmus. Okay, so we have a nice picture we put in down. There is different types of nystagmus. There is horizontal from side to side, vertical up and down, and there's torsional in a circle. So presence of, like, always remember, if you have to take one big point from this presentation, vertical nystagmus, always think about a central cause. There's something serious going on when you have, like, vertical nystagmus. Always remember that, okay? Now, so you need to look at the vestibular ocular reflex, like what happens. So when you take the right head turn, right vestibular, it goes to right vestibular nuclei and nerve gets stimulated. And then left cranial nerve with 6 nuclei and lateral rectus gets stimulated. Left lateral rectus turn to the left eye, and left and right medial rectus turns to the right eye and also to the left, and where head is turned to the right, both eyes fix, gaze to the left, okay? Always remember this nice picture. Now we have to look at the central vertigo. What are the, we talk about the peripheral, let's look at the central vertigo causes and how to differentiate between the symptoms. One is vestibular migraine, vertebrobasilar TIA, and brainstem infarction, and the cerebellar infarction. So the duration of vestibular migraine is minutes to hours. Vertebrobasilar TIA is also minute to hours. Brainstem infarction, day to weeks, and cerebellar infarction also day to weeks, okay? The character of vertigo, again, in vestibular migraine, you got recurrent episode, okay? And the vertebrobasilar TIA, you got single or recurrent episode. Brainstem is always sudden onset, right? And the cerebellar infarction is also sudden onset, we know that. Age, adults, older patient, older, when you get older, more like vertebrobasilar brainstem infarction, the cerebellar infarction. Now, looking at the risk factor, in vestibular migraine, always remember there's history of migraine, and the vertebrobasilar, usually there is like a vascular or cervical trauma, and both of them, in the brainstem infarction also can have trauma, and then other cerebellar infarction mainly can associate with the vascular and hypertension. Now, the main thing also is, let's look at the neurological symptoms, okay? You got migraine headache in the vestibular migraine, vertebrobasilar TIA, you got other brainstem symptoms, and the brainstem infarction, you can lateral medullary signs, and cerebellar infarction, we know, the classic, there is gait impairment, limb dysmetria, dysphagia, diplopia, dysarthria, those symptoms going to be there, okay? Now, you have to differentiate. Let's look at the main symptoms from the peripheral versus central. At any time, the main thing, when I have a patient come with the dizziness, always kind of remember, we need to roll out the central causes, which is very dangerous, right? So we're going to look at, and in this beautiful slide, what are the difference between the peripheral vertigo and the central vertigo? Let's look at the peripheral. It's most common, right? 80% of the people. Central is like only 20%. Inner ear pathology in the peripheral vertigo, that we already talked about in the BPV, the pathophysiology. In the central, mainly the brainstem or cerebellar lesion. Peripheral vertigo is, again, sudden onset. The other one also, central, could be gradual or sudden onset. Severe intensity in the peripheral. In the central vertigo, maybe like a mild intensity. Peripheral, worsen by position, and the central, minimal change with the position. And always look at the nystagmus. We talk about the nystagmus. In the peripheral is unidirectional nystagmus. The other one could be horizontal. You have to look for vertical. It's, again, a red flag, and bidirectional. And in peripheral vertigo, there's no like neurodeficit, and the other one you can have focal deficit. And the causes peripheral, we talked about BPPV, acute otitis media, labyrinthitis, Meniere's disease, vestibular neuronitis, trauma. In the other, central, you can have meningitis, encephalitis, cerebellar hemorrhage, tumors, and temporal lobe epilepsy. Okay? And the other causes, like look at the other causes. Of course, you have to roll out orthostatic hypotension. Everybody know it can cause, dizziness, migraine, neurological conditions, Parkinson's disease, multiple sclerosis, autonomic dysfunction is also affected, right? Anti-seizure medication like antidepressants, sedatives also have a role in it. Severe anemia, we know, can cause dizziness, hypoglycemia, carbon monoxide poisoning, okay? So the treatment always identify the cause. What causing it, and then you treat it. Can divide into 3 groups. Treat the underlying disease. You do symptomatic treatment with maybe antihistamine, benzo, antiemetics, and you're promoting vestibular recovery. Thank you so much for watching. Please subscribe to our channel. It will help us to make more videos like that, okay? Again, thank you so much.